Thanks, Denise. Before I start, I also would like to pay my respects to the traditional owners of the land on which we're seated, the Mwinana people, and pay respect to those that have passed before us, and to acknowledge today's Tasmanian Aboriginal community who are the custodians of this land, and to acknowledge all the traditional owners of all the lands from which we have come to be here today. And also to acknowledge everyone here, and thank you for inviting me to speak. I am incredibly happy and fortunate to be here today, and I just actually want to talk about, from my personal perspective, about why I'm here today and how I came to be working in this, focusing on this area at the moment, which is responding to emerging drugs of concern. So, as Denise introduced, I'm a doctor. I'm a clinical director of one of Australia's hospital-based services for the treatment of alcohol and drug problems. And I started at that service at St Vincent's Hospital in Sydney around 7.5 years ago. And at that time, we were running a specialist stimulant treatment program. And then within a few, and actually at that time, the demand wasn't so great. And then slowly, within a few months, demand started increasing, and anecdotally, I started to hear concerns from other hospitals, other health services, and one week there were 3 quite unusual events that came to me via various networks that occurred in 1 week. So I spoke to our colleagues at the New South Wales Ministry of Health, and they have a fantastic real-time database in New South Wales that was set up around the time of the Olympics to be able to detect outbreaks of gastroenteritis or something like that that was going to be potentially on a large scale and affecting lots of people that needed quite prompt response. And they looked at their data and they said, it looks like there's almost a straight line increase in presentations to emergency departments that are recorded as related to methamphetamine. So we collectively were sitting on that information collectively, not really sure how to work together or whether this meant anything. Police were certainly reporting also increased arrests. We had national border data coming in that was suggesting increased seizures. Our colleagues in Victoria were saying ambulance presentations related to methamphetamine were on their way up. And certainly the data, in retrospect, a couple of years later, looking at the national hospital data set, we could see that there was this increase in people experiencing harm of a significant amount to actually, in this case, be admitted to hospital with a methamphetamine-related principal diagnosis. But we were too late. This happened before any of us could actually start collaborating, coordinating, guiding an effective health-based response. And the media really got hold of the narrative and just started to describe the way that we were going to be reacting collectively and arguably increase stigma around people who use drugs, increase stigma around people who use methamphetamine, and increase collective fear and panic around this drug that was knocking on our borders. And as this article back in 2013 said, well, turning our young kids into zombies. And this isn't the first time we've been caught up in a methamphetamine-related media kind of barrage. We had warning, we've had practice. We've done this once or maybe even twice before collectively. So my position here, and the reason I want to be talking to all of us here, is that we need to be doing this better. We really need to be informed earlier when things are starting to emerge that are causing harms, and we need to be responding much more quickly, and we need to know how to respond. What do we do today, even today when we get a seat at the table in one of the many inquiries and special commissions? We have the Special Commissioner here today from New South Wales that is also launching another investigation in what to do. Even when we do get a seat in the table as health professionals, we can't even say what works best and what doesn't, where we should be putting dollars, where our governments should be putting dollars to make the most impact for the most people, how to close the gap between first emergence of problems to entering treatment, which some data suggests is around 10 years. It could be longer or shorter for some people. So we haven't got it together. And what treatments have we got to offer? To date, there are very little evidence-based treatments. We know that counselling can work. We know that good quality counselling that's accessible, that is delivered by people that are trained and supervised in a supported environment, by people that can access it regularly. We know that works, but who's got access to that? What's left as yet there is no evidence-based pharmacotherapy. There is left in the public mind as only detox rehab. That's the only intervention that's around. And while we all know that there is a place for that for some people at some times in their lives, in some locations, it is not a treatment system. And it is not something that we can respond with very promptly when new things emerge. And we have really, I would argue, done ourselves a disservice with responding to methamphetamine, but we've got a chance to come together and do better. What we have now out of the Nationalised Action Strategy is some funding for this new service, the National Centre for Clinical Research in Emerging Drugs. It's not it's not a centre in itself. It is a consortium of, sorry, I'll just go back there, a consortium of the three national centres and a clinical partner, St Vincent's Health. And the idea for that centre is to be starting to look at bringing together some of these pieces around research, around translation to practice, and around building capacity for research. But before I get to talking more about NCRED, and as you introduced, this talk is all about NCRED, I want to talk about where we're at in terms of finding new interventions, because that's one of the other aims of NCRED. So we need to be developing new interventions, testing them, and then including them into practice. So what are we doing at the moment in Australia? I searched recently the Australia-New Zealand Clinical Trials Registry. Now, bearing in mind clinical trials are just one of three types of what we consider clinical research, the other types being quality enhancement or quality improvement kind of interventions, and the third being data mining and looking at administrative data sets and analysing the data from that. But just the kind of traditional clinical trials research, I had a look at what we've got registered. So they're trials that have got ethics and that are being done according to standard ethical and governance processes. So the first one's actually one of the ones that we're leading, and this was a trial of a new drug, lisdexamfetamine, which is dexamphetamine but modified, so it has a slower onset of action, slightly longer duration of action. If you crush it up and inject it, it doesn't come on any quicker, so the idea is that it has less so-called abuse liability, so that if it did work, it could be given out in the community without such a desire for a close supervision on a daily basis. So the idea for studying this drug actually came to me from a client who saw that it had just been registered in Australia for the treatment of attention deficit hyperactivity disorder at a lower dose, and he thought this might actually be a medication with similar stimulant properties to dexamphetamine but a little bit better. We should give it a go. We agreed with him, so the first thing we had to do was test it, to see it was safe at doses higher than you give to kids with ADHD, in people that are using methamphetamine every day, maybe 2, 3, 4, 5 points. Is this safe? So we started this process in 2014. We're now at the next stage of multi-centre randomised controlled trial, which is the gold standard. We're still only halfway through recruiting. So when we talk about time from the starting to generate a new idea to actually turning it into something that can be then translated into clinical practice, it's at least a decade. So we need to multiply efforts, and we need to be doing multiple things on multiple areas at the same time, but also making sure that what each of us does is done at a sufficient scale to generate meaningful results that can then be translated. The other 3 trials that we saw that are currently registered is a study of N-acetylcysteine for methamphetamine dependence. Rebecca McKetton's leading this. She's also involved in the previous trial, the lisdexamphetamine trial. She's also involved in this one, just to give you an idea of the small scale of the effort. A lot of effort being done, but not enough of us involved, I would say. So this is, James Ward is leading this project, and Rachel Rowley's published this protocol paper that's looking at novel interventions for methamphetamine use amongst Aboriginal communities. It's around 9 communities around Australia, and this is an adapted web intervention that might be useful for that community. And finally, again, another one of ours is this is an app at the other end of the spectrum. So people that are not seeking treatment but might want to get some information about their own use, about harms related to that use, and we're testing it with a large anonymous online sample. We're about to go to recruit start recruiting that sample to see if for people that might benefit from treatment, whether it might encourage people to recognise problems and seek treatment. Again, we started working on this in 2014. So again, without huge pharma money or other huge injections of money like in the US, where there is quite a significant research funding base, we're struggling to go quickly. So the birth of NCRED, and we're excited to do this. And the idea of NCRED is that we bring research and clinical practice together, that we embed research in clinical practice. So we see questions that are being asked that are relevant to consumers of services and people who use drugs, and relevant to the clinicians who might deliver those interventions. And that we want to build that capacity to do that research and collaboration between researchers and clinicians, where clinicians are time poor or not interested or capable in doing research, at least having a collaboration and bringing those research questions together. And then making sure that what we do in practice is evidence-based, and when new evidence arises, that's translated more quickly into practice. Right now, how do we know what we're doing is evidence-based? How do we know that we are actually achieving what we want to be achieving? It's very hard for any of us to answer a lot of those questions. We're not really, I don't think we haven't got these elements together well enough, and this provides us an opportunity to do that. But it's a process of actually coming together and talking about it. It's not us doing it ourselves. So the first part of this work is developing what we've called the National Clinical Research Network Working Group. So it's the idea that for Australia, we do not yet have a clinical research network in the alcohol and drug sector. So we've brought a number of researchers, clinicians, representatives from NGOs, consumer representatives, have come together and agreed to be part of the first phase of this. And I have to say, as a collective collaborative effort, I am incredibly touched and honoured and privileged. This group of people has given up an enormous amount of time and expertise, including on a Sunday morning just recently, to start to shape what this might look like. And the group oversaw some of the first activities of NCRED, which included peer reviewing a capacity building and 3 seed funding rounds. And yesterday we heard from that first set of seed funding recipients, and the work and the innovation that this has generated is really quite exciting. And we can talk. You can see some of those presentations online if you would like, or we can talk more about what they were. But it is really a testimony to the kind of innovation and thoughtfulness that's out there, and then the capacity to build on that. The other thing that this group is overseeing are 2 fellowship programs. So that's where we allow clinicians working in clinical practice to have half their time paid for a year to then work on a research project of their choice. And we've had a first round of very high quality applicants applied, and 3 were nominated. 2 of those will be working on this projects that are seed funded as well. So it's sort of the baby steps in getting forward, but to bringing us together, to building our research capacity, to be identifying new things that we can do in our clinical practice that might work. The next step from this, though, is to actually bring together to form a formal clinical research network that can be part of some of the Australian Clinical Trials Alliance, so that it's a way of actually delivering new research ideas when the paths and the collaborations are already worn. So that's the next step aspirationally, and we'll need to have a lot of discussions and conversations and talking to many, many people to actually identify that, but that's the next step with that project. One of the other things that group did is that they functioned as the expert review panel for a priority setting study. So where are the research priorities in this area, methamphetamine and emerging drugs. So that group oversaw a survey that was put out to the whole of Australia, and I thank anyone in the room that might have completed that survey or participated in that, and then did a kind of Delphi process, a ranking of the priorities. And out of that, the priorities that were identified, 3 of them, there was actually a 4th one that is relevant to the next part I'm going to talk about, which was to test drug checking services and their effectiveness of integrating them into an early warning system. So whilst we'd love to be involved in that, we don't have the policy-making capacity just at the moment to make that feasible. We're certainly happy to be involved, but there are 3 others that were very similar around testing social media messaging to alert consumers and to reduce harm, to test the effectiveness of linking that to an early warning kind of system, and then also testing the effectiveness of different types of behaviour change communication with consumers. One of the things that we just heard from Jane Buxton in Canada was that one of the initial prompts to them setting up a similar kind of network in British Columbia was that the coroner released a warning saying high potency opioids available here, and so then they had a rush of people to where they thought that here was. So it was an example, and the authorities weren't, the service providers, the overdose response networks were just not ready for that kind of messaging to go out. So the way that the messaging is designed needs to meet the needs of the people that are being messaged with and to and about. So we are setting up what we're calling a prompt response network, or not setting it up, stewarding it is a better word for it. And it's a system of information sharing that is focused less on monitoring and retrospective kind of trend analysis. We already have drug trends in Australia. We have a number of different data sources for monitoring trends, but what we don't have is a signal alert to be able to actually respond where we think it might be important. So it's more of an event-based monitoring and response network. And the first part of this work, it was informed by a scoping review that Amy Peacock did. I've updated it this year. That the loose network of people that we brought to discuss the way that this could be done together used to inform their work. And you notice it's called prompt response and not early warning. And you'll see now why. This is a list of some of the people that have been involved in this effort, which is it's going to be a big effort, and we hope. I'm talking about it today because I actually want all of us to be involved in it somehow, because I think this needs as many thoughts as we can. So that was, I clicked that before people could take photos because they're not the only people that are involved. A lot of people have been involved, and it's a loose network. We haven't actually formalised yet into something where everyone has clear roles and responsibilities. But the reason we're calling it prompt response rather than early warning, this is an example of the UNODC Early Warning Advisory, which was established. There's a portal, people can put information in, but it's between member states, so the information is closed and it's used very much for policy making, and they release reports for the public with quite some lag, but it's much more aimed at law enforcement and policy makers. And recently, this year, they've opened up a tox portal where toxicologists from all over the world can enter information online for new or unusual toxicological episodes. But again, the main purpose of this is to identify new substances to be included into the international conventions and covered under national frameworks. So it's very much a different end to the kind of end that we're looking at, which is immediate communication to clinicians and consumers about potential hazards. The European early warning system, again, is similar. It's an arrangement between member states. It has official focal points, and again, it's much more directed at high-level policy and lawmakers. And they do release information on new substances that are detected over the years, but in terms of a real-time, consumer-oriented network, that's not its purpose. The US National Drug Early Warning System is much more oriented towards clinicians, researchers, concerned citizens, and it's a virtual community, and they have a range of different ways of communicating and searching and scraping information that's coming through on a regular basis. And also if a new or unusual event comes to them, they can do investigations or even hotspot investigations and get samples if they'd like. So this is getting closer to the kind of thing that we think is necessary for Australia. That one's housed at a university funded by the US federal government. And just recently, the Drug Abuse Warning Network has just been rebooted in the US, and that's just for emergency department data, which we're seeing capacity in some of our states and jurisdictions to be looking at that emergency data on a more regular basis as well. England is trialling a system called RIDA, the Report Illicit Drug Reaction. They've used the same model that they use for reporting a pharmaceutical drug reaction, that a clinician from an emergency department or a mental health service or a drug and alcohol service can actually go online, fill out a report and report it into the authorities. They're trialling it to see if that might identify on a more timely basis substances that are causing health-related concerns. The Dutch model is perhaps more consumer-focused. It's based on the Drug Information Monitoring System, which I'm sure many of you will be aware of. There is a network of more than 20 drug checking facilities where people present with drugs that are tested, even first line a colorimetric kind of qualitative testing, second line a certain proportion of the samples if they're at all concerning, or if their powders are sent to a centralised lab with a 1 week turnaround of the data. So that allows for frontline harm reduction information or health promotion information at the same time as a weekly surveillance system feeding into the Dutch surveillance system. And attached to that, people get individualised results if they've handed in drugs, but there's also an app you can sign up to. I took a photo of this myself, of one of the recent substances that they've put on what's called the blacklist. It's only in Dutch because it's only for the Dutch population. They're making no claims to have relevance outside of Holland. So this is a 2CB. This was sold as 2CB, but it actually wasn't 2CB, so they're putting out an alert for what it's worth. They also have a higher level of alert, which is a red alert, which they've only used, I think, 4 times in the last several years. It needs to be the first line risk assessment needs to be convinced it's of considerable public health threat. So one of those alerts, for example, was heroin that was being missold as cocaine to tourists. So tourists were turning up in Amsterdam buying white powder, thinking it was cocaine and overdosing, and actually it was an important public health event. So that was an example of something that was important enough to have a red alert to avoid this so-called alert fatigue. I think it's because we're talking about event-based monitoring, I think it's important that we also look at infectious diseases. And ProMed's been going for decades. I don't know if you know this. This is an email listserv, if you like. You can sign up to it. Anyone can send in an event. And it has moderators all around the world that look at the validity, credibility of the first line report, and then it goes to a top moderator, and then information is released publicly within 24 hours, and they get about 20 alerts a day. They release about 7, and you can sign up to different types. There is actually poisoning you can sign up to on this, but because it's used mainly for infectious diseases, that's very undersubscribed, so the information from our perspective is not so useful. But in terms of a system, it's simple and it's been going for a long time, and it does seem to be an important way of sharing information amongst people. And that ProMed feeds into another system, Health Map, which is based out of Boston, where they take in a whole range of different information. They do trawling of various data sources on a 24-hour basis and release that information on a location-based map out. And you can sign up at any day and see if where you are is subject to any outbreaks or anything of concern. You can see where we are today. There's one suspected measles and another unknown. So we're pretty safe here today in terms of infectious diseases. The last model that I want to look at is one that we've just heard from, you'll see it at the end, Jane Buxton, who's been involved in this in Canada and in British Columbia, just kindly joined us by Skype to answer our questions about this system. And this is the Drug Overdose and Alert Partnership, DOPE, which was set up pretty much as a crisis response in the first phases of the opioid overdose epidemic that Canada is experiencing. And it was a collaboration between different groups of people that are interested and involved in that overdose response. So it's a crisis response. It's very much like any kind of public health crisis response that is set up to communicate information between people during the response. And there are, as part of that, systems of alert that people can send in concerns that they might have by email, on the internet, by text, and then they can get alerts out. So this is an example of one that is put out through the web, but they're very much location-based. So it's not, if you're in Hobart, you won't get this alert on your phone or your email or your internet if that's what you're interested in. So it's a locality-based. The size and scale of that epidemic is quite a different context to the kind of thing that we're talking about here, which is being able to detect something new coming through or something concerning coming through. But we have good learnings from that. What we have already in Australia, as you know, are networks of people communicating information between themselves. So this is an example of the kind of use already of social media amongst people that are consuming drugs. And there are also jurisdictional networks that are established. South Australia has brought in as a network of police, health providers, toxicologists, consumers to talk regularly and share information regularly. New South Wales also is doing something similar. So it's not that these communication networks are not happening. What we're trying to talk about is how we can have something that people can send in notifications, have them moderated and reliable information out to people who use drugs, but also to clinicians, so that clinicians know what to expect and what they're looking for. Quite often, someone working in the emergency department with an unconscious person or someone who looks like they've got some kind of toxidrome will need to base their assessment on what they know is epidemiologically common or possible at the moment. So having an understanding of the circulating drugs and their effect and the combination of those different drugs is really important for clinicians at the front line as well. So this is the kind of thing that we're proposing, is a notification system with a reporting portal with separate reporting for health professionals and everybody else. A closed network to share information internally. So that's where there might be confidential information or there might be sharing of anecdotal information that isn't confirmed sufficiently to release into the public but can be shared internally, and review by experts like networks of toxicologists that are already in existence, and then information out. And that information out is to be targeted at consumers and clinicians, and is done. The idea is that it'll be very much in collaboration with the local health authorities, jurisdictional authorities. What we don't know, though, is what would exactly, amongst all of this, be the role and reach of such a system. We can't have complete national reach. It will have different cover in different areas. And how effective is that going to be? How timely is it going to be? We need to test it to see if it works. We also need to be testing some of the communication messaging, so what people find the most useful way of receiving information. And will this kind of system, based on our experience with methamphetamine, will this kind of system prepare us for whatever's coming next? Will we be able to detect something? I mean, we've got little bits of hints of wanting to be able to be on the lookout for fentanyl-related harm or some of the new benzodiazepines like atizolam that might be coming forward. But what if there's something else too that we're not looking for? We know that DMT is being used. It's the most common drug purchased on the dark net. We aren't seeing it very much clinically at all. Would there be something like that happening in the community that's actually causing concern, but no one's aware of it? And how would this system help us or not? And finally, how do we link it to effective responses? What's the evidence for reducing harms and treating disorders? We've heard a lot about how to reduce harms around methamphetamine, but we actually haven't tested a lot of those assumptions. What do we do to decrease some of the health